So it's time to talk medications. And to guide us through that here today, we have Maddie Fry, over to the side there, graduated with her Doctor of Pharmacy in 2014. Then completed a postgraduate Year 1 general practice residency at the Roseburg, Oregon VA healthcare system. While there, she was greatly involved in a hepatitis C treatment clinic, joining an interdisciplinary team of one pharmacist, a nurse, and infectious disease specialist using a team approach to increase access to Hep C treatment at her healthcare system. And that experience helps inform a large part of her talk here today. Currently, Maddie is in her postgraduate Year 2 training here at CareOregon, and her primary practice site is at the Beaver Creek Health Center. Give it up for Beaver Creek in Clackamas County. Please join me in welcoming Maddie Fry.
All right, so I'm mainly going to be talking about medications and hepatitis C, and then at the end I'll review some of the medications that Dr. Zaman talked about in his talk earlier. But there's 3 things that I want you to take away from this talk. The first is I'd like you to comprehend how rapidly hepatitis C treatment has changed in recent years. The second thing is to be able to identify medications to avoid in liver disease, which we've talked about 2 of them with Dr. Zaman already. And then the third thing is I want you to be able to identify and apply primary care patient education points for medications that are used in hepatitis C and complications of cirrhosis. And at the end of my presentation, there'll be a little activity where you can practice using primary care education points about those medications. So hepatitis C treatment is kind of like learning a new language. This slide, I called it a drug name translator, but essentially it's just the generic or abbreviation of the medications used and then their brand names. I might go back and forth between names. I usually like to use generic names, but they're so long when it comes to hepatitis C treatment that you will see me going back and forth. So this might be a slide that you need to refer back to. So Dr. Zaman already touched on this, but I think it's important to have a foundation about the history of hepatitis C treatment before we understand the treatment now. So he mentioned back in 1992, we had our first treatment for hepatitis C come out, and that was interferon alpha. And who in the room is familiar with interferon? What do you guys know about it? It was a horrible treatment, right? Flu-like symptoms, psychiatric side effects. And then, as he mentioned, it's injectable, so patients had to use injections. 5 to 20% SVR, so basically 5 to 20% of people that were treated with interferon were cured. Then in 1998, we added a medication called Ribavirin to the regimen. And Ribavirin against hepatitis C, the mechanism is actually unknown, but it increased the SVR rate from 5 to 20% to 40 to 50%. Then in 2001, PEG came out, and PEG is interferon, but basically it just helps keep the interferon in the body longer, so it's at a more steady state. So it works exactly like interferon, which I didn't say how that works, which basically just accentuates your body's own immune response to the virus. And it was able to increase our SVR rate to 54 to 56%. And that's most likely because it's steady in your body, so the patient doesn't have to take as many injections, and so the compliance was better. And then boceprevir and telaprevir, Dr. Zaman mentioned, they're actually old news now. They were DAAs that came out in 2011, but had to be used with interferon and with ribavirin. And they raised, depending on the patient population, up to 75 to 80% the SVR rate. So treating hepatitis C now, in the last 3 years, hepatitis C treatment has drastically changed. back in November of 2013, the first DAAs came out, Meprevir and Sofosbuvir, and when they were originally approved, they were used with interferon and Ribavirin together. And now we say they're all oral regimens, so we take the interferon part away. And 2014, we had 2 new medications come out, Ledipasvir-Sofosbuvir, and then this medication is Viekira Pak. 2015 in July, 2 more new medications, and then just last month, a new medication came out onto the market. And I'll talk about each of these, for the most part, in detail. So for treating hepatitis C, it's important kind of as a foundational knowledge to know that there's multiple genotypes of hepatitis C, 6 actually. And the majority of patients infected in the United States are infected with genotype 1, so that's 70% of the population. And the genotype matters because it actually will determine the regimen that you choose when you're choosing your treatment regimens. But for the purposes of this talk, we're going to focus on genotype 1, because with the new medications, a lot of them have been studied in that population because it's the largest of the group. Just to give a little bit more background about SVR, we're kind of saying that it's cure, but I think this slide kind of gives us a good visual. So a patient can actually start out, usually if they have chronic hepatitis C, can start out with a hepatitis C viral load of over 1 million viruses in their body. Then when they're treated with the new treatments, it'll bring the viral load all the way to undetectable. This undetectable line is 25. And treatment continues, and then you have end of treatment. And what they consider to be the cure is the sustained virologic response, and they measure that 12 weeks post the end of treatment. And that is in the new studies as what they use. The SVR12 predicts a 99% SVR24, so that's 24 weeks out, and then that predicts that you are cured. So hepatitis C treatment demands that we assess patients for readiness. When I was working in the hepatitis C clinic at the VA last year, one of our main duties was to assess patients for readiness for treatment. So the provider might select them, but then we needed to do a phone call. And we were involved as pharmacists in that phone call because some of the readiness talk is drug-drug interactions, and then also adherence. So we went through their history, adherence to medications. Do they have adequate psychosocial supports to get through the treatment regimen? We've taken away interferon now, so it's not as demanding of a treatment, but it still should have support. Are they psychiatrically stable? Also not as important without interferon, but something that we took into account. And then, as Dr. Zaman mentioned, drug and alcohol always should be evaluated and addressed before starting treatment. There are 3 things, I've already mentioned 1, that have to be taken into account when choosing a treatment regimen for hepatitis C. First one I said was genotype, so 1 through 6 genotypes. Second one is prior treatment exposure. So has the patient had treatment with interferon or any of the ones that came out prior to 2013 and did not get an SVR when they were treated with that? And then finally, fibrosis status, meaning do they have cirrhosis or not? And these things will influence both the regimen that we choose and the duration of the regimen, so how long they're on the therapy. Because of these factors, I can't go through every treatment regimen with you because obviously there's going to be a million. So we're going to talk about just patients that have genotype 1 and who are treatment naive. And these are the guideline recommended regimens. There's 4 of them. And they're all direct-acting antivirals. And the guidelines don't actually recommend one treatment regimen over another. So just know that they have similar efficacy in general. And I did not mention this earlier, but so the SVR in 2011 got up to about 80%. The SVR now, with most of these regimens, is above 90, as close to 99%, depending on what you're using. So the first regimen is Harvoni, and this regimen is made up of 2 medications in 1 pill, Ledipasvir and Sofosbuvir, combined in 1 tablet. And this is a really easy treatment regimen for people that have had prior treatment experience with interferon, because it's 1 tablet once a day. On each of my slides with the regimens, I include this hepatitis C virus and RNA. And this is not for the purpose for you to memorize exactly where the drugs hit on the virus. I just want to drive home that it's working directly on the virus to stop replication. And you'll see that they will, each drug regimen will hit it at different places. So Harvoni, when working with it last year, I would say was one of the most well-tolerated of the medications that had recently came out. Patients just really don't have adverse effects that they feel to this. And a lot of the patients that we were treating had previous interferon before. So sometimes they'll have fatigue and headache, but it's just not a big deal. Major drug interactions associated with it are things that block liver enzymes. And in this case, we have St. John's wort and rifampin. But with any of these drugs, and we'll talk about this a little bit more later, it's important to take drug interactions into account. And then finally, I already mentioned this, 1 pill once a day. It's a great medication for compliance, and they only take it for 12 weeks. Next one is Viekira Pak. This one's really interesting. I don't know, have any of you ever seen a Viekira Pak before? So Viekira Pak is actually made up of 2 tablets and then 1 tablet daily. So it has 2 tablets of these 3 medications here and then 1 tablet of this medication. And so obviously it's kind of a complicated regimen, but the drug company made a little box for each day that the patient has to take so it's in a big pack, and it comes in a little box for each day. And it has the 2 tablets on one side in the morning, and then 1 tablet twice daily in the morning and at night. And it's actually labeled with a sun in the morning and a moon at night. So they did that because they're competing with Harvoni. It's one pill once a day, and this one's a little bit more complicated. But you have Ombitasvir, works similarly. Peritonitis and Disubravir, all hitting at different places on the virus. And then this medication is really cool. They added ritonavir. Who in the room has heard of ritonavir? And where do you hear about it? Yeah. So ritonavir is not actually treating the hepatitis C in this case. It's being used as a pharmacologic booster for this medication because ritonavir actually blocks enzymes in your liver that would break down the peritapravir portion of this medication. So they added it to keep it at a steady concentration in the body. It's kind of a cool concept. So Viekira Pak is associated with a little bit more adverse effects than Harvoni is. Some of those that weren't noted with Harvoni are skin reactions and insomnia. Back last October, it actually had a drug warning come out that it can cause serious liver injury. And so that's mostly in patients with advanced liver disease. So it may be something that people are not comfortable using in patients with cirrhosis at this time. Because I already mentioned the ritonavir, because of that, as a pharmacologic booster, it boosts a lot of other meds. So this medication, I would say, is known for its drug interactions. So if someone was getting ready to start it, that would be something that we would need to look into. The third regimen is Sovaldi and Olysio. And in Harvoni Regimen, the portion of Harvoni Regimen, we already had a sofosbuvir. Harvoni was Ledipasvir-Sofosbuvir. This is sofosbuvir by itself as one pill, and then cimeprevir by itself as one pill. This one, so they have to take 2 tablets once a day, kind of easy. And I keep forgetting to mention this, but with these drugs, depending on if they have cirrhosis or not, the duration changes. So 12 weeks, non-cirrhosis, 24 weeks, cirrhosis. Sofosbuvir, we've already talked about. It's generally well tolerated. It's in Harvoni Regimen or Ledipasvir-Sofosbuvir, and the drug interactions are mainly here. Cimeprevir, if you ever come across, I don't know why you would, but it can only be used in combination. So if you ever came across cimeprevir by itself, that would be a red flag. And then adverse effects. This one has one that is of note, and that's photosensitivity rash. So we always counsel patients to use sunscreen. And then this is a pretty new regimen. Daklinza came out in July of 2015, so I actually don't have personal experience using this regimen, but we've got Daklinza, and then it's combined with Sofosbuvir, which we already saw, like Sofosbuvir. And then finally, Ribavirin can be added if a patient has cirrhosis. So in this regimen, they require the Ribavirin addition. What's interesting about Ribavirin that I said earlier is that it doesn't really have a mechanism directly on the hepatitis C virus. They don't know how it works, but it so I can't really speak to the adverse effects of Daklinza because I don't, but these are the ones that are recorded in the drug information. And then with all of these medications, just all of these things are not good. We keep seeing them over and over again. And that's because they're strong CYP3A4 inducers, which is a key enzyme in your liver. So Ribavirin has 2 important adverse effects that if a patient ever started Ribavirin, they would need to be counseled on. The first is hemolytic anemia, and we monitor for that if someone is started on it. You monitor it with the hematocrit and hemoglobin. And this is the only medication used in hepatitis C now that can be dose adjusted. So if someone does have a lower hemoglobin level, if they're starting to develop that, you can make a dose adjustment to to the ribavirin and see if you can keep it steady. All of the other doses are across the board. You're not going to change those. And then birth defects is the second one. It shouldn't be used in women who are pregnant or in male partners of women who can become pregnant. And that's for the time that they're on the medication and for 6 whole months after that. And this point really got driven home for me because I counseled someone at the VA on ribavirin. And of course, a lot of our patients are a little bit older, 65-year-old gentleman, and I feel funny counseling him. But then the next time he shows up to the appointment with his wife and baby. So it kind of drove home for me that it's not something you want to skip, even if you make assumptions about someone.
So what type of birth defects
It causes, I looked into it yesterday, I thought someone would ask me, but it causes like 4 or 5 different birth defects with really complicated names that I can look up for you and send to you, but.
So it would be like a category X.
Yeah. So adherence is key to getting that SVR, for getting that cure. And I think this is where, as nurses and as pharmacists, we can really make a big impact on patients. If you see someone in clinic on one of these hepatitis C regimens, it may be something you could educate them about and just talk to them, make sure everything's going okay. There are plans that are made for missed doses with these medications. Usually patients are counseled on what to do if they miss a dose, and it does depend on medication. So at the end of this talk, there's actually some handouts from the VA that are really specific about what a patient should do for each medication, but I didn't include them. And then in the beginning, usually you'll see clinics, Karista can maybe speak to this later, but they will give a really short duration of medication. They're not going to write it for the full 12 weeks on day 1. In our clinic, we usually gave 1 to 2 weeks supply of the medication, see if the patient can tolerate it, make sure their labs are going okay, and then move on from there. Reiterating one more time, hepatitis C meds interact with a lot of drugs. I put hepatitis C or interactions on your slides specifically, but this I think might be something you could use in primary care I want to just show it to you. Should I do this, Paul?
Yeah, go for it.
Okay. It's cool because you can actually pick out the regimen that a patient's on. So one drug interaction I didn't talk about was PPIs with Harvoni. They're acid suppressors. And then you can search an alphabetical list. And the cool thing about this website is it actually, let me see if I can find it. Now I just know this one memorized, but it'll give you instructions on what to do about the drug interaction. So with Harvoni and Ledipasvir-Sofosbuvir, it actually tells you that the patient, if they have to continue that PPI, they can take it at the exact same time that they take the medication, but only then. So they can't take it in the morning and then take the Harvoni later in the day. So that's why I really like it, because it kind of tells you about it, but it tells you what to do about it. So just in general, though, these regimens are really short. They're not like the old regimens where they were like 48 weeks long, or they're 12 weeks long usually, some even 8 weeks. So what I would recommend during that time is not starting new medications at all, if it can be avoided. But if you saw someone come through primary care that was being started on a med, that might be something you want to just red flag your provider and say, hey, is this really necessary until this is over in 4 more weeks? So Dr. Zaman did a great job talking about this. So we have Tylenol. He said it's okay to use. I found that it's limited to 1 gram in patients with cirrhosis, 2 grams in those that have Hep C without cirrhosis. And then NSAIDs, we already talked about, generally safe at standard, but should be avoided in patients that have cirrhosis. 2 other things I wanted to talk about when it comes to over-the-counter products and liver disease. First is iron. You kind of already touched on that, but when you have Hep C, you can actually store excess iron in your liver. And so unless someone has diagnosed iron deficiency anemia, you want to avoid iron, and that includes in multivitamins. And then complementary alternative medicines. So many of these patients are trying to do whatever possible to keep their liver in good health. So they really look outside of, I've really noticed this, a lot of them will come in on milk thistle or other CAM products that they found are good for their liver. There's no definite benefit for patients with liver disease for complementary alternative medicines, but it's fine for them to take them if they're not on therapy for treatment for hepatitis C. If they start hepatitis C treatment, these need to be stopped because they're not studied. We can't look them up in the drug interaction checker, and we do not want to risk them not getting an SVR because they were taking a complementary medicine. So I think a lot of the conversation recently has been about the cost of hepatitis C meds, a lot of the controversy. And I just wanted to confront this head on a little bit, look at, so it all depends on the regimen chosen and then the duration of how long it is, but it can range from $63,000 for an 8-week regimen all the way up to $300,000 for a 24-week regimen. And we did just have a medication come on the market last month that I mentioned at the beginning, and it's predicted that it'll bring the cost down into the $50,000 range. But as nurses on the front lines, I would assume that you might have many patients coming to you and asking if hepatitis C treatment, is it the time for them to have hepatitis C treatment? And the answer to that question is multifaceted. We already went through some of the things that have to be looked at. But one thing is kind of complex is the cost issue. And last year, in fall of 2014, I heard this Radiolab clip. And I wanted to share it with you because I think it kind of made me realize the complexity of the cost issue. And I don't think it answers the question. I just think it points out how complex of an issue it really is. It's only a 2-minute radio clip, and I'll just play it for you. All right, and then later on in the talk, they actually specifically talk about Sofosbuvir, but I think it just kind of summarizes for you in a much better way than I can the complexity of the cost situation when it comes to medications right now. I think this will be a conversation that continues to happen as we move forward. So I encourage you to listen to this whole story. Yeah.
Can you speak to the criteria for coverage at CareOregon?
So I can a little bit. It actually just changed. Do you guys want to talk about it at all, or?
I thought you had it. Sounds like.
It's in the handout. The criteria is. So we cover those with cirrhosis, and then it just changed that we will cover, so fibrosis score 4 is cirrhosis. Fibrosis score 3 is right before cirrhosis. So we are now going to be covering patients at fibrosis score 3. Medicaid only. Thank you to Kofi.
Question.
Yeah.
So would I be wrong in stating that in Europe and other countries, Canada, for instance, these drugs cost a lot less?
Yes.
Does that not belie the big pharma's arguments regarding development costs, since they're selling them so much cheaper elsewhere? Why are we paying so much more?
It's a good question, and I don't have the answer to that, unfortunately. Yeah, and I'm not going to make an argument for Big Pharma in front of you either.
I'm looking at the assessment and readiness for treatment. Can you speak to the psychosocial, any thing that you're concerned about?
So I'm trying to think of it might be a better topic for Karista. I don't know, I can't think of good examples of, in our case, we actually made patients come back to the VA to pick up their meds. So do they have support to get there? Are they able to even they might be able to be adherent to taking the pill, but can they come back on a regular basis to be monitored? Was kind of a big thing. So we did provide, transportation and all that, but just going through whether or not they're going to be able to make it.
Question.
Yeah.
When you talk about drug and alcohol use evaluated and addressed, are people who are still drinking and having binge drinking started on these drugs?
No, they are not. We require 6 months abstinence.
Well, it's also 1 to 2 drinks a day for now. As long as you're within that, don't go over that.
Okay.
It's a big barrier.
Do they, so with the ECOH, are they required to be tested every so often?
Oh no, we don't require testing.
Some CCOs do though.
Yeah, we don't.
So based on the side effect profiles, cost aside, why would a clinician prescribe any of the other treatments other than Sofosbuvir, Cimeprevir, or Harvoni?
So good point. Daklinza I don't think's been around long enough for me to make an argument. So that drug we'll have to just wait and see. Yeah. It's Daklinza with Sofosbuvir. And then.
But then it's Ribavirin, which is something you probably want to do.
Right, if they're cirrhotic though. So if they're non-cirrhotic, then we could just have Daklinza and Sofosbuvir. So can't really speak to that. Cost aside, honestly, there really wouldn't be a reason because Viekira Pak, as I mentioned, has lots of drug interactions, so it just wouldn't be usually the number one choice.
One other question. So can you talk a little bit about antifibrotics?
Antifibrotics?
Well, Up to Date talks about caffeine being an antifibrotic for folks in cirrhosis. Dan Shen and another Chinese medicine whose name I can't pronounce, they're supposed to help reverse fibrosis.
So the source I used, and I would consider all those to be complementary alternative medicines, it said that there is no data when it comes to liver disease for any complementary alternative medicine. Definite data that shows benefit for their liver. So we always recommend, obviously they can stay on it when they're not in treatment. Yeah. Post-treatment, we don't really make recommendations for one way or the other when it comes to that. All right, so I gotta move on to pharmacologic management of cirrhosis-related complications, which we pretty much talked about all of these with Dr. Zaman. The first, ascites, just reiterate, sodium restriction, he said 1,500, I think that's good advice. Then fluid restriction, it's not as important as sodium restriction, and he said the cutoff was 125. Here I said 120, so it's only necessary if the serum sodium is less than 120. Diuretics for pharmacologic management of ascites are the gold standard, and there's 2 diuretics, furosemide and spironolactone, that are mainly used, and they're used in combination, and they're used in combination to actually decrease the risk of hyperkalemia, because spironolactone, I don't know if you remember, is what's called a potassium-sparing diuretic. So if you use it alone, it can increase patients' potassium levels. So SBP, Dr. Zaman didn't really talk about. It's more of a complication of ascites. So like having a spontaneous bacterial infection. They use paracentesis to diagnose, and this is just a slide used to show when you would use empiric antibiotic therapy. You can go through it yourself. I think for the purposes of this talk, and I want us to have a little bit of time for the activity, I think knowing that in uncomplicated SBP, so if someone was in primary care, you'd see these medications used for the treatment. So they're oral regimens, antibiotics. Esophageal varices, we talked about, and we have beta blockers, and Dr. Zaman did a really good job talking about this as well, so I don't know if I need to reiterate it, but 60 going to the heart rate. I have 55, but most patients can't tolerate that low of a heart rate. So you're going to titrate the dose up. And just to kind of explain the drug a little bit more, so it's a beta blocker, decreasing the heart rate, decreasing the cardiac output, and so therefore decreasing the pressure inside of the varice.
Question?
Mm-hmm.
So why is metoprolol not indicated there?
I don't know the answer to that.
Yeah.
Oh, okay.
What was the answer?
Because it's non-selective.
It's
It is selective.
Metalol is non-selective, so it's.
And the total has more cardiac.
You want to know, it's more blood pressure versus metalol is more focused on heart rate.
Hepatic encephalopathy, this is my last one. We have the first line, which is lactulose, and you all are probably familiar with lactulose as the way it decreases the neurotoxin level or the ammonia is by having a patient defecate. So 2 to 3 stools, it's titrated to 2 to 3 stuffed stools a day. So it's not the most fun medication to take. The second line is an antibiotic called rifaximin, and it actually works in the colon. It's only 0.4% absorbed systemically, so it goes into where ammonia is made by bacteria in your gut. and it kills those bacteria. And usually you have to use lactulose first, and if a patient can't tolerate it, you could use rifaximin. And sometimes if a patient does not have cure of their hepatic encephalopathy with lactulose alone, you can actually add the rifaximin. So these are some resources I just wanted to point out to you. The Hepatitis C Advocate, I think, has really great handouts. There's a handout in the back of your stuff from Hepatitis C Advocate. And I like it because you can actually kind of talk through some of the studies that are with the drugs with patients, because I think it gives them confidence to see, oh, I really will get cured with this medication. And then the second, patient education, I have a bias, but the VA has really good hepatitis C handouts. So if you ever need to talk, that might be a good place to check out. Drug interactions, I showed you that website. And then nursing education, they actually have, I don't know if it's free, but you can go through all the PowerPoints for free, and I used it to learn more about hepatitis C before doing this talk. University of Washington has a hepatitis C website called hepatitisc.uw.edu. All right, well, that's it from me. Can I allow them to go on break? Or is that your job?
With great power comes great responsibility. I think Spider-Man said that. So, great job. Let's hear from Maddie Fry.